Hello, welcome everyone. Thank you for joining us. My name is Julie Bershadsky. I am the Director of Community Living and Employment here at Institute of Community Integration at University of Minnesota. Thank you for joining us for the latest edition of the Policy Forum. We at ICI try to do these on a regular basis every couple of months. Sometimes it's a little bit more, sometimes it's a little bit less, but on average about 2 months. The topic today is based on the latest edition of our policy research brief, which I will show you in a second. That topic is, as you will see on the screen, institutional bias in long-term services and supports for people with IDD. We're going to be talking about publicly funded services particularly. Some housekeeping notes. This is being recorded. The recording will be posted on our website along with the slides. So we'll give you the link at the end of the presentation. It usually takes a couple of days for this to go up, but it will be posted. Today's discussants, I'm very happy to say, are Dan Berlin, Director of Federal Policy. I'm sorry. Today's discussants are, let me start with our group. Today's discussants are Brian Bajan and Sheryl Larson from Institute on Community Integration, Agnes Cole, who was a Lund Fellow at ICI last year, and we're very excited and happy about this, Michael Gamel-McCormick, who is the Disability Policy Director for the U.S. Senate Special Committee on Aging, and then also Heidi Hamilton, who is a Disability Services Director at Minnesota Department of Human Services. And then we're also joined by Dan Berlin, who is the Director of Federal Policy at NASDS. He's not an official panelist, but we wanted to introduce him because he may chime in on a discussion once in a while. I will also ask them to introduce themselves shortly. As with all of our forums, this is an informal discussion. So chime in either via voice or chat. Feel free to do that. We will also have some audience discussion questions at the end where we really would like all of you to participate. One reminder is to please be respectful of others' opinions. We're kind of assume that we're all working from the same place. We may just have different opinions on how to get there. So with that, let's get started. And I'm going to ask first Sheryl, Brian, and Agnes to introduce themselves. So this is our ICI team who is responsible for this brief and organizing the forum. So Sheryl.
Hi, I'm Sheryl Larson. I'm the Director of the Residential Information Systems Project. I am a white woman with glasses, blonde hair, a pink shirt, and a maroon and gold background.
Brian?
Hi, everyone. My name is Brian Bajan. I work at the Institute on Community Integration. I am a white male. I have glasses. I've got a maroon University of Minnesota polo shirt and a gold University of Minnesota background. And my pronouns are he, him. And I work on the Residential Information Systems Project with Sheryl and also the MTI project.
And Agnes, you're up on deck.
Hi, my name is Agnes Cole. I am a self-advocate and a cohort of Menen Fellowship at the Institute on Community Integration, and I am an immigrant.
Thank you. Thank you for joining us too. Okay, Michael?
Good afternoon, everybody. I'm Michael Gamel-McCormick. I'm a bald white male with a white goatee, and my background is a glassed-in porch. I'm the Disability Policy Director for Senator Bob Casey. We cover disability policy from prenatal to death, and I'm glad to be here. Thank you.
We're very glad to have you. Thank you. And Heidi, last but not least, almost last, definitely not least.
Hi, everybody. I'm Heidi Hamilton. I'm the Director of the Disability Services Division at the Minnesota Department of Human Services. I am a white woman with glasses and medium length gray hair. with a navy blue shirt on today. I've been with the Department of Human Services for almost 20 years, but have only been in this role for a little over a year. So I'm so excited to be here today. Thank you.
Thank you for joining us. And Dan, quick hello from you.
Hi, everybody. I'm Dan Berland. I'm the Director of Federal Policy at the National Association of State Directors of Developmental Disability Services. I am a middle-aged white man with everyday grayer hair and a gray beard. And as Julie said, I'm not an official panelist. I am mostly going to be listening, but I have been invited to chime in and may do so once or twice, but you're in pretty good hands with the panelists you've got.
Thank you, Dan. All right, so thank you all for being here. As I said today, today's policy forum is about institutional bias in service systems for people with IDD. The topic is based on our last issue of the policy research brief, which is shown on the slide. You're not expected to actually see the text or anything. We just wanted to show you what the brief looks like. It's a 2-page front and back with some graphics. We will use the brief to sort of set up the issue and have the discussion. Each of our forums is based on one of these briefs. So let us launch in. So today's research issue is, well, I've said it multiple times, but I'm going to ask Ryan to talk about a little bit more about why we're talking about this and what the actual issue is. Brian, on to you.
Thank you. So the Intermediate Care Facility for Individuals with Intellectual and Developmental Disabilities program is Medicaid's institutional option for people with IDD who need long-term services and supports. The Medicaid home and community-based services waiver option allows people to get services at home or in their preferred community setting rather than an institution. The 2014 HCBS settings rule ensures that people receiving HCBS programs have full access to the benefits of community living and are able to receive services in the most integrated setting. While ICF IID services are guaranteed, HCBS waiver-funded services are not. States are not allowed to have waiting lists for ICF IID services, but they can have waiting lists for HCBS waiver-funded services, and this results in an institutional bias in long-term supports and services for folks with IDD.
Thank you. So that's the crux of the issue, and we will be developing our discussion around this issue. We will first show you some data. So to sort of understand where that data comes from, I'm going to ask Sheryl Larson to talk about the background of the data and the background of the study, the risk study.
Thanks, Julie. So we are using 2 different data sets to describe the issue that we're talking about today. The first data set is the Residential Information Systems Project data. That is a project that we collect longitudinal data nationally for about the living arrangements of about 1.4 million people who get services through state IDD agencies, which is why we have Dan Berland and Heidi Hamilton on our call. This project is funded by the Administration on Community Living and is hosted at the University of Minnesota. The other project that we are using data from is the National Core Indicators. That is an annual in-person survey of adults getting IDD services in almost all states. It is managed by the NASDs and by the Human Services Research Institute, and it's funded by state memberships.
Thank you, Sheryl. Do you want to talk about NCI as well? National Core Indicators?
I did.
Oh, sorry. Okay. Apologies. I was multitasking for a second. Okay. So that's the data that we're going to show you. Those are the 2 sources of the data that we're going to show you. Those pieces of data that you'll see, they come directly from the policy research brief. So they're just pulled from the 2-pager that you saw. And we're just going to go through key finding one by one. So first key finding is about cost And Brian and Sherry, would you explain to us what this shows?
Yeah, sure. I'll start off by speaking to the ICF IIDs. So in fiscal year 2019, the average annual per person costs for folks living in ICF IID settings was about $140,000, compared to the average annual cost for HCBS waiver funded supports was $48,500. And so what goes into those costs? So for ICFs, the costs are the same for all people living in a facility and include the same set of services for everyone. This includes nursing services provided round the clock. The highest costs are for state-run IDD facilities that were built to serve many more people than currently live in them. Most were built more than 100 years ago and have high maintenance and upkeep costs. And these include room and board costs. And Sherry, do you want to speak to the HCBS services?
Sure, it costs a lot more money to serve person in an ICF than it does in an HCBS setting. There's a lot of reasons why HCBS average expenditures per person are less. One of them is that more than half of HCBS waiver recipients live with a family member who provide many hours of uncompensated support and supervision to the person. In an ICF, all of the supports that are provided by paid caregivers. The HCBS waiver does not include room and board costs. Other funds are used to cover those expenses, including supplemental security income and state subsidies. HCBS recipients only get the services that they need and that are authorized in their individual service plan. They do not get the same package of services across the board. People who get HCBS funded services may want or need more services than they are authorized to get. In other words, even if they're not on a waiting list to get into the program, they still may be waiting to get enough services to meet their needs adequately. And again, there are many people waiting for services. So,
Thank
and then one final comment about this, and these are just two of many Medicaid funding authorities that are available to support people with intellectual and developmental disabilities. We're pointing these two out because the ICF program is the legacy program, the institutional program of Medicaid, and the HCBS waiver program is by far the largest, the most used funding authority for people with intellectual and developmental disabilities.
Thank you, Sherry. There is a question in chat that is very relevant to understand this data, so I'm gonna read it out. How was the HCBS waiver data collected? This number reflects people living in their own home, but there are people on waivers here in Minnesota that have budgets that exceed $140,000.
Yes, so this is an average, it's a national average of the expenditures per person for waiver recipients. And so different states have different averages, and within each state, people can have very different average expenditures, all the way from $1,000 per person for some people to well over $500,000 in a few local cases. So the data were collected from state directors of developmental disabilities or their designee, and then summarized on a national basis.
Good, thank you. That was important to understand. Okay, so my first question then is sort of based on this finding. So my first question to our panel is, why does knowing this matter for federal and state policy? So why do annual per person long-term care services and support expenditures actually matter for federal and state policy? And whoever wants to kick us off, please go ahead.
I can go ahead, Julie.
That would be great.
So first of all, related to the question that was submitted, I do have the data for Minnesota. The average DD waiver cost per person is $82,000, which is still less than our ICF FDD costs. So it is a little higher than some of the other states and higher than the average. It's really important for us to know that these numbers, because Medicaid for people with disabilities and seniors is one of the largest areas of our state budget in Minnesota. So it's really important for us to be able to show that we are being cost effective with that funding, and to show legislators that we are being good stewards of that of supporting people in the best way possible. And a lot of times I think people think that an institution may be more cost effective because you can put people together and share resources. And so it's really important to be able to show, especially our legislators, that in actuality, HCBS services are more cost effective and are much higher quality of life for people as well.
Julie, I'll jump in here as well. From a federal perspective, we need to make the same decisions that Heidi makes in Minnesota as well. So having the numbers on average is important to share with the members of Congress as they're considering adaptations to the Medicaid program, and particularly to home and community-based services. The demand nationally for HCBS has grown exponentially. Depending on the survey that you look at, there is somewhere between 85 and 95% of people prefer HCBS services to a nursing home or some other facility or institutional type of service. That clearly indicates that there needs to be an understanding of what the cost is for HCBS in comparison to the facility-based services. From a more policy point of view, the public policy is all about balancing the needs of people and the cost that that policy might be. So we need to understand the dollar figures and also recognize that buried within that 140,000 or 48,000 is a great level of variation too, just like Heidi said. Sometimes home and community-based services can be expensive. Heidi said 82K in Minnesota, which means it can travel into the $100 or $110 or $120,000 level in some cases in some states. But it is important to understand what the cost is so that we can go forward with policy that can serve as many people as possible.
That makes a lot of sense. Thank you. Okay, there's a question in chat that is an interesting one, and I'm actually going to ask Sheryl to speak to this. Are the populations served by the two mechanisms? So we're talking about ICF and HCBS waiver. Are the populations served by these two mechanisms any different in terms of demographics, medical complexity, resources, etc.? And before I hand it over for the answer, I will say that there are multiple states that have closed all of ICFs, all of their ICFs, so all of their institutions. So the populations that were served there are now being served in HCBS. Sheryl?
Yeah, I that's kind of where I was going to start. There are very few people now living in ICFs. Actually, Minnesota is one of those states that still has a lot of people in ICFs, but they're in small ICFs. There really aren't any important differences between those two populations in terms of there is an analog for every person that's living in an ICF today. There's another person in that same state that receives services under the home and community-based services waiver, just as complex, just as many difficult costs. This is a point that policymakers will get all wrapped up about, but honestly, given that 17 states have closed all of their state-operated institutions, which are almost all ICFs. We know that in those 17 states, they are serving everybody who the state institutions used to serve. So there may be a handful of people who, for example, are in ICFs because they are court ordered to be there, and there may not be a home and community-based services waiver option for that particular population, but that is a very, very, very rare exception. You cannot use that as reason for describing these two cost differences in any meaningful way.
Thank you. And thank you for the question. That was a good one. That actually is a good segue to our next sort of key finding that we'll discuss, and that is, in addition to difference in cost and the fact that the same populations can be served in both, as Sherry just described, we do find that there is a difference in people's outcomes. And this, I'm going to ask Sherry and Agnes to talk about this and describe what is shown here.
Agnes, you want to go ahead?
Yeah, people living in smaller communities certainly have more choices. Research using the National Code Indicator in-person survey shows that people living in smaller communities certainly have more choices in what they eat, where to go, what time to go to bed, what they do with their free time, and how they spend their money. They also have more say in what support them and where they want to live. And I would like to give my husband as an example, where he lives at home and he have the right to have a case manager. He have right to respect and privacy, including restraint in that setting. Sherry?
Yeah. So, this slide talks about people in smaller settings have more choice. What we know for sure is that HCBS settings on average are smaller. First of all, the majority of people who receive HCBS waiver funded services live with a family member, 60%. Amongst the 40% who don't live with a family member, the average size of the place in which those people live is 2 people per setting compared to 11 people per setting for ICF IID settings. So we have good research evidence using the NCI survey that smaller settings offer more choice, and that HCBS settings are smaller. People who receive HCBS services do have more opportunities to control their lives.
Thank you. Okay, so that is what is shown here. But I would like to pose another question to our panel. The first one sort of being basic one, I think this was already discussed a little bit, but why is it that HCBS recipients, people who live in smaller settings, why is it that they have more choice? There are theories about that, or research. And then sort of a follow-up question is, how do federal and state policy, how do they support choice? How do they support people in the system being able to make choices? So what are the policy views on this?
Let me just take a quick crack at your first question, and then I'll turn it over to our policy staff. The key reason why people in smaller settings have more choice is that the more people who live together, the more structured the setting has to be in order to meet everybody's needs. When there are 2 people living in a home sharing a bathroom, there's not a lot of fighting that has to happen about who's going to take a shower bath first and what time those showers or baths are going to be. When there are 6 people who have to get ready by 7 a.m., there's a lot more structure that needs to be put around what time those showers are. Similarly, when there are 2 people living in a home, it is much easier to get people to agree upon what dinner is going to be, what time dinner is going to be, or where they're going to go to do something fun. When there are 11 people sharing a household, figuring out a meal that would suit the needs of 11 people, or figuring out a place to go where 11 people will agree, is much more difficult.
Okay. And then the follow-up was, how do federal and state policies support people being able to make these choices?
Yeah, I'll start. And I just want to highlight the HCBS rule that was issued in 2014 from the federal government that really required states to make sure that people have choice and set policies in place. That that rule was issued in 2014, and here we are in 2023, and some states are still working to come into compliance with that rule because it was such a shift in how some states were doing things. Minnesota, which I think was already really progressive in making sure people had choice, we had person-centered planning requirements already in place, and we had options for people. We just got approval within the past year on our plan with the federal government. So it was really significant in changing the way that HCBS services are delivered. In addition to that, Minnesota has done some things to make sure that people have options. One thing about Minnesota, and it probably isn't unique to Minnesota, but we get stuck in a model. So when we did our big deinstitutionalization in the 1980s, people moved to 4-bed group homes in the community, and that's still, until the early 2000s, that still was the primary way where people on our waivers program were receiving services. In 2009, we instituted a moratorium on the growth of those types of settings to really encourage people to have other options in the community. And that was really a challenging policy to implement because people loved 4-bed group homes. That was looked at as this is where people are going to be receiving services. And so we've really, over the past couple of decades, have been trying to shift to smaller community settings where people can have those choices that Sheryl was talking about, where they just have 1 or 2 roommates and they can make those decisions, or they're living on their own and making some of those decisions as well. And then also in Minnesota, we've in 2020, we implemented a new Medicaid state plan option to help people find and keep their own housing, and it's called Housing Stabilization Services, and it's available through Medicaid, so people don't have to be on a waiver program to access it. And the idea is really to help people live in their own home and find their own home, and then have waiver services to kind of wrap around that. So I think we've been trying to do a lot in Minnesota. We still have a lot more work to do to really encourage more individualized settings and figuring out how to support people. A big challenge that exists now and has just been exacerbated by the COVID epidemic is the staffing shortage. So that is one thing that plays into it. We can have all the best policies that we want, but if we don't have staff to deliver the services, then that's always a challenge.
It seems to be a sort of overarching crisis proportion issue at the moment. That's yeah, okay. I'm gonna catch up with the chat a little bit. Oh, Sherry?
I was just hoping we could hear from Michael before we do that.
Sure, I'm glad to do that, Sherry. Reinforcing what Heidi said, for sure, the 2014 settings rule has taken 9 years to implement. Part of that was COVID delay, but also because of what Heidi said regarding states having to really make a shift. I do want to mention that one of the hidden pieces here that we don't talk about a whole lot is that while HCBS may afford a lot of additional choices, it is not for everybody, unfortunately, those choices, because HCBS typically are targeted populations in many cases. Sometimes they're people with autism, sometimes they're people with physical disabilities, sometimes they're people who are older adults with disabilities, and that can often leave out other people who would desire home and community-based services, but because it is not a required service through the 1965 Social Security amendments, there are waiting lists, as Julie has alluded to and Sherry has alluded to. So we need to look at how do we provide HCBS to everybody who wants it and desires it, not just those that are within the definition of the waivers that each state writes.
Thank you. And I just wanted to, there's a question in the chat that is a clarification question that I think would be helpful to just respond to real quick. So what is, Sherry, what is considered a small ICF? Can it be in the community? Is it like a licensed site? Just so people understand what we're talking about.
So the intermediate care facility program has a size minimum of 4 people. There cannot be an ICF setting that has fewer than 4 people, but there's really a lot of differences there. So there can be smaller ICFs, but they're still an institutional service. They still have institutional rules. They have a lot less flexibility about how the service is provided. They don't require the same things that the same provisions that the home and community-based services rule requires in terms of access to food at any time, access to visitors when you want, all kinds of things that are in rule now for HCBS recipients that are not in rule for ICF recipients. And it really does exacerbate this difference between people in ICF settings versus wave HCBS settings. Size isn't the only issue in play here. The rules around these services also have a tremendous impact on the kind of lives that people live.
Thank you. I think that's a good clarification. There's a question from Holly that I think I'll read it, but I think we'll leave it for later because I think it'll fit better with our later discussion. What about housing for people using HCBS? This costs money. Accessible, affordable homes are hard to come by. I think we'll touch on that a little bit later, but Holly, I'll leave it until a little bit later if that's okay. The question from Sherry, about the HCBS setting rule. So is there a plan on a federal level to require states to be compliant with the HCBS setting rule by a certain date? I think Michael you might be
so Dan, back me up here, but I believe that date was March of 2023.
Yeah, that's exactly right. I didn't think I was going to chime in, but I think this question lends itself to talk about the national federal policy from the administration. So the original compliance date was set back several times, ultimately to March of this year, which folks have said 9 years. It was not pushed back again. So states are expected to be in compliance now with the rule. However, CMS made it very clear that mostly because of COVID, because of how COVID impacted our world, but also because of the staffing crisis that Heidi referred to, and especially the way those two things combine with each other to really make this a whatever the next 3 steps up from crisis, whatever that word is, that there would be an opportunity for states to submit what's called a corrective action plan to say, we are in compliance with the rule, except for these items, and these items are specifically impacted by the staffing crisis and COVID, as exacerbated by COVID. And here is our plan to come into compliance with those specific items. And here's our timeline. And then that would be negotiated with CMS so that CMS could make sure it was something that was a reasonable timeline. It can't be forever. And the only other important distinction there is CMS did say that there were a set of sort of what they considered very basic rights that were not negotiable within the framework of a cap. So some of the things that Sherry mentioned, like being allowed to have visitors in your home when you want, being able to eat food at your home when you want, having a key, having your own key to the place that you live. All of those things, CMS said, we're not going to include in these caps. By March of 2023, states had to be compliant with those parts of the rule.
Great, thank you. See, Dan, we're so happy that you're on. Okay, there's one more question I will leave for later about evidence whether there's the staffing shortage has led to more of a shift back to ICF services. I think it'll be a good question to touch on in one of our next slides or one of our next key findings. Before I go on though, very quick clarification. Again, Sherry, I think you're probably best to address this. Are most of the big settings, big institutions run by for-profit agencies?
Okay, so most of the biggest settings are run by state IDD agencies or state Medicaid organizations. But in terms of the non-state ICF settings, states vary a lot in terms of whether they allow for-profit providers or not, and the balance of for-profit and not-for-profit providers. There's been a little bit of research looking at whether the for-profit, nonprofit sector impacts Medicaid institutional settings differently. But I guess what I would say about that is it's not the biggest issue around ICF settings. There are much bigger issues in terms of people's rights and opportunities and access to community settings and those kinds of things.
Thank you. All right, we'll go on to our next finding. And I'm going to ask again Brian and Sherry to describe what is shown here. There's a graph.
Yep, I can start. So the ICF IID program started in 1971, and it grew to about 148,000 people by 1993. Before beginning to decline. The size of ICF IID facilities also continues to decline. The HCBS waiver began in 1981. By 1995, there were more HCBS recipients than people living in ICF IIDs. The number of HCBS waiver recipients continues to grow. Most of the growth in HCBS funded services is for people living with family members in their own home or with a host or foster family. 90% of children and 45% of adult HCBS recipients live with a family member. Medicaid has added funding options that states can use to provide HCBS services to increase access.
Michael already pointed out that most people who get new recipients of services, the vast majority are choosing HCBS funded services. And the sheer numbers of people getting HCBS services, this is just amongst people with intellectual or developmental disabilities. It does not include all of the other population groups that might be eligible for these services. We're at almost 1 million people in 2019. I think by the time we analyze our 2022 data, we probably will exceed 1 million people with intellectual or developmental disabilities in those settings.
So then my question to the discussants is, given this growth and given this, large growth in HCBS recipients versus ICF, to what extent did this sort of happen naturally? Or do these differences grow in differences in the number of HCBS recipients versus ICF recipients, whether they reflect federal and state policy?
Well, Julie, I think that if you look back to, again, 1965, and when the Medicaid program was created, it included, for anybody who was eligible, a right to be in a nursing home or another type of facility. The assumption in 1965 was that that's where somebody who has long-term services and support needs would be. That was the general perception of the country at the time. We get to 1981 and we get to a family from Iowa who has insisted that their child who's been living in a hospital for 3 years be able to be served at home. And we begin to see a shift that these supports and services can take place in home settings and in community settings. And that in those cases, people do very well when the supports are in place. They, one of the things that I like to point out about HCBS right now is that HCBS in many ways is the greatest funder for employment support that we have as a policy in the country. We think about vocational rehabilitation at about $4 billion a year as that support. HCBS funding for employment services is far beyond that. It allows individuals to be in the settings where they want to be and to participate in those settings. And the shift of what people with disabilities can do and where older adults want to live has been dramatic over the last 50 plus years.
Heidi, anything you'd like to add from Minnesota's perspective?
Sure. Our Minnesota's numbers align with this absolutely. One thing to point out is, you know, as the number of IDD goes down, it's not in direct correlation with the number of waiver recipients. And what we found is that people of who are in ICF IED tend to be white, older population of people. And what we're finding is people who are enrolling in HCBS are often from more diverse communities, people of color. And what that says to us is the way that those services are delivered are more in line with what those cultures think are important for serving people with disabilities. So I think that's really important to keep in mind as we're developing our policies around HCBS and figuring out the next thing that we're going to do to increase access to those services and really be thinking about the population of people that are accessing those services.
There was an interesting question on chat, and I don't know whether we'll actually be able to answer this, but I'm going to pose it to our panel. Does HCBS waiver expansion improve staff retention? And then there's a second question as a follow-up to that. Or is lack of funding not the primary driver? So in my view, they're kind of two different questions, but I'll ask the panel to tackle this one. So HCBS waiver retention expansion, any indication that it's going to improve or is improving staff retention? And is the lack of funding primary driver?
I will yield to Michael.
So I can talk about this from my boss's point of view. He has spent the last 3 years trying to infuse the state systems with additional dollars for home and community-based services because of the fragility of the state networks that provide services, and that fragility is around the workforce. We have almost in every single state a crisis in the workforce. When the COVID pandemic started, the average pay for home and community-based waiver direct service provider was somewhere around $12. With the additional infusion of funds that have been put into the system, that has started to hover around $14 an hour. I can go down the street and get a job at a Wawa for $18 an hour right now as a starting person without any other skills. So the market is very, very difficult right now, and it is very hard to recruit and retain people. Certainly there are other characteristics that keep people in positions: good management, good training, fair benefits, all of those type of things. But when I can have a differential of $4 or $5 in a retail counter store versus work that is extraordinarily rewarding but also very demanding, it is very difficult. So we need to actually invest more in this workforce.
Thank you. Okay, before I go on, just a quick, another quick comment in chat. There's a question that I'm going to actually respond to. Does using an HCBS waiver automatically mean the person is integrated and included in their communities? I would say absolutely not. It does not automatically mean anything other than you're receiving the HCBS waiver services funding. Another, so from the same person, quick question for Sherry, I think. Do these numbers, the numbers that we're seeing on the screen, do they only include people who are on the DD waiver, or do they include other waivers as well?
Yeah, it's an interesting question. And in Minnesota, we have several waivers that serve people with intellectual and developmental disabilities. We ask states to tell us about people with intellectual and developmental disabilities who receive home and community-based waiver funded services. And we include waivers that it's not just the 1915C waiver, but also managed care waivers and a couple of other categories. Whether states are reporting to us numbers of people with intellectual and developmental disabilities on waivers other than the IDD waiver depends on how their systems are set up. In some states, they only can count people according to the waiver that they're on. In other states, their data systems are robust enough that they can tell us, yes, there are this many people with IDD on the IDD waiver, there's this many on the CAC, this many on the CAT, and so they can give us a number for that. So I do want to make one other comment about the resources available to fund services, which is a little bit off topic in terms of the growth of services, except to say that one of the strategies that states used during the pandemic to address this incredible staffing shortage was to pay family members to provide services. What that did is it took family members who were having to stop working in their other jobs because they had to provide services, especially families of adults, because they had to provide supports to their family members, and gave them an income to replace the income that they would have been making had they been able to work outside of the home. I think that is probably one of the strategies that we're going to have to employ broadly if we're ever going to make any progress on addressing the workforce shortage. I also, and this is a personal opinion, it doesn't reflect any political opinion, it just is a personal opinion. We don't have enough working age people in the United States right now willing to take these jobs. We need to increase the number of working age people in the United States somehow. I will say it that way. And stop. Did I answer your question though?
Yeah.
Okay.
Thank you, Sheryl. There are a couple of more comments in chat related to the workforce crisis and how to deal with it, career ladders, and also whether it's an actual funding issue or how that money is used. But we'll get to that, I think. We'll talk more about the workforce and the shortages. At this point, I'll want to continue and go to our last sort of key finding, and that has to do with waiting lists. So Agnes and Sheryl, please tell us what is shown here and what the issue is.
So they said in 2019, 194 plus persons living in their own homes or with a family members in 30 states were waiting for HCBS waiver funded support. So if you look at the map, you'll notice that 930% are receiving funded support and 194 plus are still on waiting list. And in my opinion, sometimes I feel that maybe state because of the waiting list, maybe state changes their eligibility, streaming time, or maybe some states are not streaming participants before putting them on the waiting list. But
yeah, the waiting list numbers are difficult to explain, right? Because there's different ways to describe it, but let me just tell you how this number comes out of the RISC project. In the RISC project, we ask states specifically how many people who live with family members or in their own homes are eligible for HCBS services, not currently receiving HCBS services, but are waiting for HCBS waiver funded services. And so there are a number of states that do not have waiting lists anymore for the HCBS waiver funded services. They're using another source of home and community-based services funding, another federal funding authority. There are other states that have very large, we don't include Texas in this number because Texas, if you ask them, depending on how you ask them, the answer could be there's 500,000 people waiting for services in Texas, but that's because they have an interest list, not a waiting list, and that interest list has not been adequately screened to find out if people are eligible for services, if they're still alive, if they still live in the state, or any other kind of characteristics. So this is 194,000 people in states that continue to operate HCBS waiver funded waiting lists.
So chances are, if anything, the number waiting is probably larger than this. This is likely an underestimate.
Well, and then yeah, I think the other thing to remember here is this does not include people who currently get HCBS waiver funded services who are in need of and asking for additional resources to get their needs met, but are not actually getting those services. So there are many, many more people in many states who don't get everything that they need or in some cases want. And there was a question earlier about kind of the impact of expanding eligibility for the HCBS waiver. If we expand eligibility for HCBS waiver services through whatever mechanism we use it, and we don't increase the amount of dollars that are available in total, what will happen is there'll be more people competing for the same bucket of services. And when we do that, there will be less money available per person that gets those services. And so initiatives that want to expand the number of people who are eligible for a certain set of services without also expanding the resources available will by definition require that some people who are getting more services now will get less services. So this issue of the waiting list is actually kind of complicated and has a lot of different elements that have to be considered.
Okay, thank you. All right, I would like to pose another question to our panel. So these waiting lists, and considering this is probably an underestimate, what are our policymakers doing about waiting lists, federal and state level? I would like to ask Michael to start because I know Michael has to jump off likely in 10 minutes. So Michael, federal level.
Thanks, Julie. So my boss has 4 things that he is proposing, and this is not necessarily only to address waiting lists. This is also to address the workforce concerns as well, which, to Sherry's point, is wrapped up in whether or not we actually are able to deliver the services and home and community-based services to people in need. I do, though, however, want to go back to the point I made earlier that there is extraordinary variation in waivers across states. You can go from Idaho to Iowa to Indiana and be eligible or not be eligible for specific types of services. So unfortunately, we're not talking about a national program. We're talking about state programs that serve certain populations and provide certain types of services. That is problematic in and of itself right now, given the mobility of our society, and frankly, what puts a lack of mobility for a lot of people who need the long-term services and support. But to address your question, Julie, my boss has proposed 4 pieces of legislation. One is called Better Care, Better Jobs Act. It is a infusion of $300 billion into the HCBS system to the states to make sure that there are enough resources to be able to recruit, train, and retain a workforce. And Sherry's exactly right that that workforce is not just the professional workforce, but it is in many cases going to be a family workforce as well. We did see a pretty significant increase in the number of states that were willing to provide payments to family members during the pandemic. We are now seeing states stop that process in many cases. Not all of them, but yeah, a significant number of them. But the Better Care, Better Jobs Act would, as I said, infuse about $300 billion into the system. The HCBS Access Act, the Home and Community-Based Services Access Act, would balance out what service is actually available to somebody who needs LTSS. They would still have the option to be in a nursing home or a ICF or some other type of facility, but they would also be eligible for home and community-based services as well. It would be a requirement of the Medicaid program in states. And as we've said throughout the last 55 minutes, that is not the case right now. HCBS Access Act would take up somewhere between $30 and $35 billion a year to implement. That's the best estimate that we have from some external sources and from the Congressional Budget Office as well. And the two other pieces that are in place is a piece of legislation from Tim Kaine of Virginia that my boss helped write as well, which would be $1 billion investment in the training of and recruitment of new direct service personnel. And then finally, you will see at the end of this month, my boss introduced a piece of legislation that will be called the HCBS Relief Act. And that piece of legislation will provide a 10-point FMAP increase for 2 fiscal years, much like the one that was in the American Rescue Plan Act that provided $12.7 billion to the states to do some of the recruitment and retention and also pay family caregivers. If we can't do the larger pieces, his theory is that let's do at least 2 years to stabilize the workforce, to stabilize the service delivery providers in each state, so that we can have reliable HCBS services. Because the reality right now is that not only can't we maybe address all of the needs, we're also seeing some providers actually reduce the number of services they provide. And in some cases, we're seeing providers actually close their doors. So those are the 4 pieces that he's addressing at this point.
That last point that you made actually gets to an earlier question that we had in chat, whether we are seeing that staff shortages are sort of making the shift go in reverse, so shifting people back to ACF because of staff shortages. So you just kind of addressed that. Thank you. Okay. Michael, do you need to go, and would you like to say anything before you do? We don't want to just go on without acknowledging your.
I appreciate that, Julie. Thank you. The last thing I would say before leaving is that my boss thinks that this is a crucial piece. We have not alluded, I'm sorry, actually Sherry has alluded to this, that when you are a family member who has to either quit their job or reduce their work hours, your family actually, your economic health becomes more precarious. It becomes worse in many cases. So what we're looking at is the need of a set of services to support people, whether it's your mother or father who's in their 90s, or it is a child or a sibling who has disabilities who needs support and services. But every time that somebody has to reduce their outside work, it often has a negative economic impact on the household. And therefore, my boss thinks this is just a critical issue, not just for dignity and support and quality of life for people with disabilities. It's also an economic issue for the family of all of those individuals, and that we have to get serious about addressing it. Which is why he has spent so much time looking at legislation that would do this. He was the one who got that $12.7 billion in the American Rescue Plan Act, and he'll continue to keep working at that. So thank you again for making the time and inviting me to come.
Thank you for the work that you are doing on this. We will post links to the legislation that you talked about at Dana's presentation. And so obviously we'll encourage everyone to go and check that out and support.
Great. Thank you so much.
Thank you for joining us. All right. I will pose on the same question that we just posed to Michael, to Heidi, from Minnesota's perspective. What is Minnesota doing or has done to address waiting lists, and maybe how?
Sure. So Minnesota eliminated our waiting lists in 2016, but I'll provide some context around that. Prior to eliminating our waiting list, we had, similar to what Sherry was describing for Texas, we had people who would get on the waiting list years before they thought they needed services because they had heard that people were waiting for years, and they may not have even been eligible. They weren't always assessed before they were getting on the waiting list. We've had situations where the legislature would give us funding to eliminate the waiting list, and then a year or two later, we would have another 5,000 people on the waiting list again. So we worked very intentionally with our advocates, with other external partners, to take specific steps to eliminate our waiting list. And the first was that we established prioritization criteria for people who are waiting and timelines for when services would be approved after the assessment. So for people who were leaving institutional settings and for people who have an assessed need that they need services within that next year, funding would be approved within 45 days if it was available. And we really had this intentional process to make sure that counties were reviewing every person that was on the waiting list to make sure that they really had an immediate need for services, or one within the next couple of months, within the next year, I guess, is what the priority was. And then once we created that, we worked with the legislature to provide increased funding, which they did. They provided increased funding, which allowed us to remove any limits on the waivers and eliminate the waiting list. So that is, when we look at our waiting list, we're looking at people who have been assessed to need services and are waiting to get those services, waiting to get on the waiver to receive those services. We know now that we have people who are waiting to get in the door with the assessment. What we've heard from our counties, who are actually the ones who are doing the assessments, the counties and the tribes, is that the workforce shortage is not just on direct care workers, it's also on professionals, social workers and nurses who are responsible for doing these assessments. And so we're having conversations now about how do we mitigate that workforce crisis. So while we say we've eliminated the waiting list, we still know that there are issues that we need to continue to talk about in order to make sure that people are getting access to the services.
Can I follow up with a question, Heidi? Which is, I'm blanking. Sorry. Go ahead, Julie.
Well, then I'll follow up with a question. This is an audience question. I don't know who it's best for, so whoever knows the answer. Can people on waiting lists for an HCBS waiver be served through state-funded Medicaid plans? Obviously varied across states, but what role can state funding and state plans play in this?
That was my question for Heidi. To what extent are you addressing the waiting list using state plan HCBS services?
Yeah, absolutely. We in Minnesota, yes, they can use services on the state plan. I mentioned earlier, housing stabilization services is now a state plan benefit where people can have help finding and keeping housing. And then also people can access PCA services. It's a pretty robust benefit. Our PCA benefit in Minnesota is pretty substantial. And we are in the process right now of working with CMS to change our traditional PCA into a 1915I and 1915K benefit, which is still a state plan service, but it provides more options for people, including paying parents of minors and spouses to deliver care. So we were able to do that on the PCA program during the pandemic, and we currently have an extension through November, and then we won't be able to do that anymore on the state plan option. But once we have this transition from PCA to community first services and supports, we'll be able to continue to provide that option, which I know is so beneficial to many people. So the answer is yes, that people can use state plan services, and what that looks like from state to state, I'm sure, is very different.
Cool. Thank you.
Yeah, and I can speak to the states that are using that option. So for people with intellectual and developmental disabilities, there are 63,000 people nationally receiving services under the 1915I or K waivers, the ones that Heidi was just talking about. And then there are 163,000 people with intellectual or developmental disabilities who are receiving other state plan home and community-based waiver or home and community-based services. And so that would be PCA, but also state-specific, whatever the states kind of negotiate as an optional set of services, or what they negotiate in terms of either their, one of the other funding mechanisms. So there are lots of ways that states are addressing this, and it makes this whole picture of waiting list be more complicated, because somebody who might be getting a HCBS state plan service, but the question is, are they receiving what they need, or are they only getting part of what they need from that service? And so it's still a waiting list issue.
Mm-hmm.
This is Dan, if I could just chime in once again. I read that question a little bit differently, because the questioner asks, what role can state funding play here? And I read it as asking, could you not the distinction between waiver and state plan, but the distinction between Medicaid and state-only funding. So to be clear, what Sherry is talking about is very important. It's all part of the Medicaid program. It's just two different types of authorities that you could use to provide services. But all of that is a federal-state partnership where the federal government will ultimately pay for, in almost every state, greater, sometimes significantly greater than 50% of the cost of the service. And that's why states use Medicaid to provide these services. But states absolutely can use their own, state-only funding that doesn't go through Medicaid reimbursement. A couple states like California many, many years ago passed something called the Lanterman Act, which basically said we'll use state funding to pay for anything Medicaid won't pay for. But over the course of since the Lanterman Act was passed, which I think was in the 70s, maybe mid 80s, something like that, don't quote me, the range of options and ways that states can use Medicaid to provide services, HCBS services to HCBS to folks, all the stuff that Sherry just talked about. There's so many different flexibilities and options that states now have, that there's really not much reason to use state-only funding, because you almost certainly be doing something that you could be doing through the Medicaid program, but you'd be saying, instead of having the federal government pay about 60% of this, we're just going to pay 100% to do the same thing. So there's a lot of reason to use the Medicaid program to provide these services so that you can reach more people, and states typically won't decide to do state-only funding instead of the Medicaid program at this point.
Yeah, the only big place where state funding comes into play is for people who don't meet eligibility criteria for supplemental security income, where their disability is not severe enough to entitle them to Medicaid services, and when the person themselves is not eligible for Medicaid, states cannot use Medicaid dollars for services to those people, and they have to use state dollars. So there is still a place for that, but it's a smaller portion. It does affect people with intellectual disabilities. People have mild intellectual disabilities sometimes who don't meet those eligibility criteria.
Thank you. there's a comment that still wrapping my head around the various federal and state funding mechanisms. Yes, I think even those of us who have been working in this field for a while are still wrapping our heads around all of these things, especially since they keep changing on a fairly regular basis. So valid. Okay, let's go on. Thank you for those responses. Brian, did you want to jump in? Oh no, you're just.
I was just thumbs up. Yeah, I
Getting
do
ready.
the work, and I'm still trying to wrap my head around it. I'm very grateful for my colleagues that I can just send an email to and get a response.
All right, on to our policy recommendations. So these were policy recommendations that were made in the two-page brief, sort of what could be done to address the issue. We're going to go through those quickly, and then we'll have a discussion around them, around feasibility, around what can actually be done. So let's start with actually going through the policy recommendations. Brian, Sherry, and Agnes, all you again.
Yeah, so I got the first one. It's to continue to reduce the use of expensive ICF IID settings.
Agnes, I think yours was the second one.
Yeah, eliminate Medicare institutional biases by making ACBS an entitlement program.
It's something
Yep.
that Michael spoke to in the legislation proposed. Sherry, go ahead.
Oh, sorry. No, it's
I
Brian.
thought you were going to jump in. Oh, yes, it's okay. Brian, back to you.
Yep. We're going to continue to promote the use of HCBS that support person-centered services, full community inclusion, and individual choice.
And then we're going to enforce all, we want to continue to keep this on the forefront. We need to enforce all the provisions of the 2014 Medicaid HCBS rule to promote person-centered services, full inclusion, and choice. There was a comment earlier about, Julie said, no, it doesn't guarantee those things. It doesn't guarantee those things, but it is promised by rule, it is required by rule that states follow, that states provide these for everybody who receives home and community-based services in whatever setting. That includes where they live, but it also includes if they live in a provider-operated setting, but it also includes what they do with their daytime. And one of the things that states are really struggling with is how do you address all these adult day programs that are segregated? It's one of the biggest challenges with the home and community-based settings rule. Anyways, I will stop because we've got a lot more to talk about in 13 minutes to do it.
Yep. All right. So with that setup, would like to have a discussion, and this is where we'll start with our panel, but this is where we ask all of you to chime in if you'd like, of course. So those were recommendations. This is what we'd like to have happen, right? So what stands in the way of implementing those recommendations? And since Michael left, I'm just gonna ask our panelists in whatever order would ever like to chime in with their views and what are the biggest barriers.
I want to go to Heidi first.
One thing I think about, so related to the entitlement, the institutional bias, our assistant commissioner testified in front of Congress in 2013 about the institutional bias in Medicaid. That was 10 years ago, and we're still having these same conversations. And one thing to think about is the institutional bias is not just about ICF, IID, it's also nursing facilities and hospitals. Those are really strong lobbies. And so I think that particularly the nursing facility industry may not want an HCBS entitlement, may want it to stay an institutional entitlement. And I know maybe I'm being very political here, but I think it's really important to figure out how to talk about it in a way that brings those providers along with us about how important it is to see, like, especially as people are aging, it's not just people with disabilities, how much better it is to serve people in the community. I mean, we're seeing that with seniors too, and not wanting to go to assisted livings as much as maybe people in the past did. So I don't know what's standing in the way, but I really think it makes so much sense to do it for so many different populations to eliminate that institutional bias.
Yeah, I want to just comment again on the recommendation. The recommendation isn't to get rid of ICFs or nursing homes. The recommendation is to give people the same access to home and community-based services as they currently have to those forms of institutions by making it an entitlement for states that have waivers, that those waivers must serve all eligible people, that they won't be allowed to have waiting lists. It's not sometimes we get wrapped up in this conversation about, well, you want to get rid of it. This is not about that. This is about leveling the playing field and letting those services compete against each other in the marketplace. Let's let people decide, give them the option of having either, and let them decide, well, what's the best thing for me.
Brian and Agnes, and would you like to chime in?
Yeah, I think about what Michael commented on the cost of the HCBS Access Act. I believe he said it was something like $30 to $35 billion, and I'm not sure if that's like an annual thing or what, but my concern is just with the cost. How are we going to manage the cost of increasing these services? I, for one, support folks living in the most inclusive environment they can. I appreciate Heidi's point that let's not just think about folks with intellectual or developmental disabilities. I think about the unpaid work, bless her heart, my mom is doing for my grandmother to keep her from a nursing home, because my grandmother has said, this is what I want. I want to live in the community, right? And then I think about concerns at the federal level with budget deficits and agreeing on what should be paid for. And I'm concerned that federal elected officials won't all be able to get on the same page to say, hey, we want to fund home and community-based services. We want to increase the funding to make it so everyone who wants to can access it. And I hope I didn't make that too political.
No, but there was just the comment that was just posted in the chat about what stands in the way. One of the reasons our recommendations is not just to eliminate the bias by creating an entitlement to HCBS. Items 3 and 4 both say we need to promote HCBS services that are consistent with the home and community-based services rule. We have a strong rule that really does change how home and community-based services are provided. And in the rule, if states do not do what they're supposed to do, they can be sanctioned by Medicaid, and Medicaid can actually refuse to pay for the service, the Medicaid part of the payment. But I think we have to do both of these things. We have to figure out a way to make it so that people who don't want to live in an institution who need services can get access to the services that they need. But we also have to continue to work very hard on implementing the HCBS rule. Love to hear from Dan at this point.
I was going to put Dan on the spot too.
Well, so I think you've covered a couple of the biggest obstacles. The funding is definitely a big obstacle. It's just a reality in terms of making legislative progress today. And we can all have various opinions about whether it should be an obstacle, but unfortunately it is. But there are a couple other, I think, obstacles or how about opportunities to address in order to get to these really excellent, to make real these really excellent recommendations. And one of them is, we've talked about it a bunch, and it even comes up in the comment that you just referred to that points out that just being in an HCBS environment doesn't mean that you're necessarily going to be integrated, and that challenges staff. Just the staffing crisis, the lack of staff. we know at NASDDDS, we have members that talk to us all the time about the fact that they have either had to put off or can't even contemplate plans that they might have had to expand their service system. There's a chat. Heidi mentioned that this is the one of the biggest budget items of the entire state of Minnesota. This is true across the country. And nonetheless, you will sometimes have state legislatures that understand the importance of expanding it and will be prepared to spend more money on it in order to expand the number of people being served. But our members are not always able to ask for that right now, because if they don't have enough bodies to serve the people that are, currently in the service system, then it's, difficult to contemplate expansion. So that is a real barrier. And I don't mean to highlight that one, because I think the funding and the other things that you talked about are probably the most important, but that is definitely a barrier to almost every kind of expansion that we would like to see. And then the other one that I'll mention is there is a really strong consensus, certainly among NASD's members, certainly among the majority of the self-advocacy organizations out there and the people receiving services, et cetera, that, and we see it in outcomes data, in actual outcomes research, that HCBS is people are just happier. They have better life outcomes in HCBS. But that is not universally accepted, not universally agreed with. And there are, Heidi mentioned, it's hard. Once we have something in our system, it's difficult to move away from it, especially if you have families and individuals where that's what they're used to. That's where they've lived for many, many, many years. And we do have challenges sometimes. HCBS, no system is going to be perfect, and HCBS is not. And there are people that have not had good experiences in HCBS, not because the data that shows that HCBS is a superior way to achieve outcomes, not because that data is wrong, but because it's not always, if the implementation is poor, then people will have bad experiences. And then those people will be quite upset to see a reduction in the census of ICF's IID, right? So that's another. We need to be. It's a call to all of us that are involved in administering these systems to continually improve and to continually hold the experiences that people have in our service systems at the very front of what we're doing to overcome that particular obstacle, right? So in addition to the money, there's other things as well that are sort of standing in the way, but all of it together should not does not make those recommendations anything less to strive for, because that is absolutely the direction our system's been moving in for the last 40 years for very good reason.
Mm-hmm. I mean, research is pretty overwhelming in terms of what it shows for people's outcomes. Just to catch up with chat a little bit, Sherry, I'll get you're next. I just want to. There's a funny and interesting comment in chat that the research is political, and what we're talking about is political, even if we want to divorce ourselves from it. I just want to acknowledge that that's probably true, and we just need to acknowledge that this has implications, and this can be and is viewed through political lens often. So. And then one more thing, Sherry, before you have the word again, there's also a comment about how we use the dollars that we have. So not just the amount of dollars, but how those dollars are used. And I want to agree with that comment, because I myself think that there's certainly things that can be done with how the actual rates are set, and the structure of the rate setting, the funding mechanisms, that can certainly use a fresh look. So we'll just agree with that. Sherry?
Yeah, I want to go back to the comment that research is political and this topic is political. It absolutely is. Policy research is political, because we're researching policies that are established by federal and state legislatures and Congress, and those are elected officials, and the decisions that they make are based on political realities in their states And we know that there are just massive differences from state to state in the resources that policy makers will allot for services. And so it is clearly a political decision. I want to raise a different issue about how do we address this institutional bias, and that has to do with the use of prisons and jails as institutions that serve people with intellectual and developmental disabilities.